Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Dear colleagues and friends, it's my pleasure and honor to be today with you in a MEOM webinar meeting. And today it's really a distinguished meeting because we are having an international eminent speaker. They are coming from different parts of the world. So we are having a global meeting in a MEOM platform. We are having Dr. Ahmed Salam. Dr. Ahmed Salam is a VR surgeon and he is working as a vitreoretinal surgeon in Arkansas in United States. And he will join us within a few minutes. Also, we are having my dear colleagues, by the way, Dr. Ahmed Salam he is the president of 8th MEOM conference. Our colleagues and my dear friend, Dr. Nazim Al-Hussein, he is a fellowship vitreoretinal surgeon, and he is working as a VR surgeon in Mediclinic Parkview. My dearest friend and brothers and mentors, Dr. Muhammad Awdallah, a well-known figure, and he is a professor of ophthalmology, Cairo University, fellow Royal College, and he is working in Cairo University. And he is the head of vitreoretinal committee in MEOM Academy. Dr. Nazim Hussein, he is the general secretary of MEOM Academy. Our also another speakers, one of our dearest friend and colleagues and mentors, and one of the pioneers, a VR surgeon in the Middle East and worldwide, Dr. Ashraf Sha'rawi. And he is a professor of ophthalmology, University of Alexandria, Egypt, chairman of Retina Congress, and he will be also with us. We are happy that we are having Dr. Ashraf. Welcome, Dr. Ashraf. Dr. Ayman Midanat. Dr. Ayman Midanat is a VR consultant and vitreoretinal consultant, surgeon, owner and chief of ophthalmologist, Amman Eye Center, Amman, Jordan. So he is Amman Eye Center, Amman, Jordan. Dr. Ayman is a well-known figure and in ophthalmology and VR vitreoretinal surgeon in the Middle East and worldwide. One of the distinguished friends, and he is an old friend of mine, and we know him long time. He's a well-known figure in worldwide and in India, Dr. Danish Talwar. He's a VR consultant, senior consultant ophthalmologist and vitreoretinal specialist, Center for Sight, and in Andhra Prasath, Apollo Hospital, New Delhi. Thank you, Dr. Danish, for being with us. Thank you. And the last but not the least, my dearest friend and colleagues, Dr. Tatiana Avanzova, is from Russia and now in Saudi Arabia. She's a VR surgeon, and also she is a member of MEOM Academy and MEOM Organizing Committee. Thank you, Tatiana, for being with us. So without any further ado, we can go to our programs. We are having two, can you please mute all speakers? We are having two parts of the sessions today. I will give a talk about biosimilar, then we can go to a surgical cases, surgical.
You are unmute.
Mohammed, you are muted.
Okay, he mute me and he didn't mute others. Okay. So my talks today, it will be about biosimilars, a new era of treating a patient with anti-VEGF in all medical or macular edema with different diseases, either DME, AMD, and others. So if we talk about biosimilar, we need to go little bit about what are the things, just a few words about the introduction about the recent year, last years, there was a significant advancement have been made in the management of diabetic macular edema or AMD, and this opening up new possibility for patients with these conditions. This emerging breakthrough includes innovative treatment options such as antivascular endothelial growth factors, therapies which have shown promising results in improving visual outcomes. With this development, the future of DME and DMD management is looking brighter, providing hope for a better quality of life for those affected by these sight-threatening conditions. Okay. I cannot move Abdullah to the next. Okay. So even with this advancement in the management of diabetic in the last, you can say 1 or 2 decades, we are still having a challenging in the management of diabetic macular edema or AMD. Some patients may not respond adequately. So a poor response for whatever we are having, an anti-VEGF or steroid. The durability, efficacy, and safety of available treatments, we are in need for more durable and more efficacy and safety of these treatments. And there is one thing also economical burden. And this is one of the most important things that we are going to concentrate in this presentation. So economical burden, it is really a problem. And so many patients, they are not able to get these medications and benefit from this era or this advancement in the management of diabetic macular edema by the presence of anti-VEGF or steroid, but because of the lack or they are unable or they don't have an affordable to get these medications. Also, another thing is the compliance of the patient with frequent injection and follow-ups. What are the current anti-VEGF therapies for available the AMD or DME? We are having many medications now. Either they are like ranibizumab, Lucentis, aflibercept, Eylea, brolucizumab, board delivery system, faricimab, bevacizumab, and the biosimilar now, which is available. If we are looking to this anti-VEGF, some of them we are still using even as an off-label of use. Some of them they are a high cost, some of them they are expensive, some of them they are having a long intervals, some of them they are risk of inflammation, some of them are having a new dual mechanism. So we are having different type of mode of actions and effect either in efficacy or in other things. Factor, this what I want you to concentrate on this slide, factors that influencing treatment selections. How we can select a treatment for DME patient. For this patient, we have to look to the disease characteristic, either the severity of disease or the response to previous treatment. So if there is a severe disease, we can't start with a weak one. So we have to go to one more stronger and anti-VEGF that can give an effect faster. Patient-specific factor like adherence to follow-up. Some of the patients, they are not coming in a proper times and they are not able to come in a very frequent as we are requesting every month. So we have to look for those they are having more durable effect rather than to give every month injection. Financial constraint, and this is what we are going to talk about. So many patients, they are not able to get this medication because of the expense of this medication. Safety and efficacy, systemic risk factors. Some cases they are having a cardiovascular problems or late CVA or others pregnancy. So there is some factor that affecting what kind of medications that we have to give for a certain patient in a certain disease. So biosimilar, we came now to biosimilar. What is the biosimilar? So biosimilar, if we want to think about it, intravitreal vascular endothelial factors inhibit have regularization in the practice of retina, but it associates with significant cost, both for patient and for the healthcare system. So the most important things that we are going to contain, what are the things that are going to provide for us the biosimilar? Biosimilar defined as a biologic that is highly similar and has no clinically significant difference from the FDA-approved biologic. The product must demonstrate, this is very important, the product must demonstrate similar pharmacokinetics, pharmacodynamic safety profile, immunogenicity, and clinical efficacy compared to the reference product. So if we are having any biosimilar Lucentis or ranibizumab, so the one who is like ranibizumab should have all the characteristics of the original ranibizumab. Their development process is longer than that of generic drugs, but still and more cost effective compared to developing new biologics. These are commonly used in many other diseases, not only in ophthalmology, they are using in many others in rheumatology, oncology, and other fields of medicine. The first ophthalmic biosimilar version of ranibizumab was Razumab, and intrapharmacologic was approved in India in 2015. Since then, multiple ranibizumab and FDA biosimilar have been in development, and many of them they are already FDA approved. So in the United States, there are currently 2 FDA approved ranibizumab biosimilars, and there is an FDA also approved like Percept also, and available now. It will be very soon in other countries than United States. What are the concerns that we have to keep in our mind? Biosimilar can be developed faster and are more cost effective than original biologic. They have the potential to reduce the large financial burden of existing anti-VEGF treatments. And it will solve a lot of a problem. At least it will cover or improve. For those patients, they are not able to get the expensive medication that we are using now. So improving patient access and increased treatment compliance. Important points: biosimilar safety, efficacy, and immunogenicity. There is some abstracts and publications. They are looking for the biosimilar, and this is one of the publication was published in Royal College of Ophthalmology in 2020. It was talking about immunogenicity and efficacy after switching from the original ranibizumab and real world data. However, the initial observational data from this study that was done in the beginning of the era of biosimilar in 2015 up to 2020, the initial observation from this study suggests that switching to biosimilar ranibizumab doesn't have impact on clinical immunogenicity and efficacy in a short term. So they are giving the same effect and same efficacy and safety of the original one. The key summary points from the previous that anti-VEGF are highly effective within the retinal disease, but cost can potentially limit the intensity or length of the therapy and thereby provide suboptimal clinical outcome because the patient not able to take his medication in a proper time, or he is not able to take the full dose that suggested for his disease. The similar candidate for ranibizumab and aflibercept are already in the treatment of retinal disease. Also, another take-home message from the previous week that the economic benefit outweigh in the treatment and increase the accessibility and affordability to care and hence immense impact on public health. Biosimilar offer beneficial outcomes across patient population with different ethnicities. This is another publication looking for the efficacy and safety of biosimilar compared to the ranibizumab in neovascular age-related macular degeneration, and the conclusion that biosimilar to the reference ranibizumab in the term of clinical efficacy and ocular and systemic safety in the treatment of the patient in case of AMD. There is another study, which is a recent study that's done, which is the fourth study, the Royal College of Ophthalmologists in 2025. The methods, they are including around 1,230 patients and received around 3,600 ranibizumab biosimilar. It was a multi-center retrospective study. And the conclusion of this that ranibizumab's biosimilar injection were effective and safe in this real-world experience with a stable visual acuity and reduce CFT with no major complications. This is some cases that are shown in this study. They are representative cases of treatment-naive diabetic macular edema, and we can see the effect of the improvement after the using of biosimilar. This is in case of AMD, also there is an improvement. And this is in a myopic macular neovascularization, also it shows an improvement while using the biosimilar. So in a different condition or different disease that having a macular edema, either AMD, DME, or myopic neovascularization, and other diseases, there is an effect of biosimilars. I will share few cases of my experience. It will be very fast. Some cases, just only one. This is a case of diabetic macular edema with also left eye vitreous hemorrhage. I will show you only just after one injection how the improvement. This is the OCT injection of ranibizumab biosimilar, and this is how it is. From the first injection, there is a really improvement in the decreased central retinal thickness after just one injection. Another cases, this is also a diabetic macular edema. This is a patient. Sorry, this one, a right eye chronic central serous chorioretinopathy with a choroidal neovascularization. This an OCT pre-injection, and you can see it here. This is the OCTA, and this is the OCT post first injection. This one also the OCTA. Both second injection and third injection, we can see how the improvement in the decreasing the central retinal thickness after using the biosimilar. This is another case of diabetic macular edema, and this is the OCT ranibizumab injection biosimilar. And even this one, as you see here, there is one cyst in the center, and this is one of the difficult responding to the anti-VEGF, different anti-VEGF, but we can achieve also, it shows there is also an improvement of decrease in central retinal thickness post injection. This is after the second, after the third injection, and this is the fourth, after the fourth injection. It's not complete resolutions of the central retinal thickness, but there is a decrease and improvement of the visual acuity and decrease the central retinal thickness. Another case, this is diabetic macular edema, and this is also a OCT pre-injection of ranibizumab, and this is after the third injection. So I didn't show the second. This after the third injection, there is an improvement of the central retinal thickness and responding well to the treatment. I will show this one, and I'm also happy that Dr. Nadeem Hussain, he is with me here, and he is with us today. He's a dear colleagues, and he have done a study about the economic impact of biosimilar in retinal disease treatment. And this is the conclusion. The future of biosimilar in treating retinal disorder hold a great promise, particularly in addressing the economical burden of long-term treatment. Biosimilar offer a potential cost saving while maintaining favorable clinical outcomes, which could alleviate the financial strain on a healthcare system, especially in developing countries where the healthcare spending is a critical concern. As the demand for biologic treatment in retinal disease grows along the aging population and raising diabetes incidence, biosimilar are poised to play an increasingly significant role in global healthcare system. The conclusion of my talk, biosimilar promise reducing drug expenditure and improving access to the high quality biologics. Acceptance and use of biosimilar can increase patient access to biological therapies, increase number of healthcare providers available to treatment patient, shift recommendation of biological therapy earlier in the treatment algorithm guidelines. Lastly, this will improve the patient outcome. And thank you very much for listening. And if there is any questions. So, any comment or questions from colleagues?
One question about the availability of the biosimilars in the area of the Gulf.
Now it's available everywhere, I think, in Gulf. Yes, in United Arab Emirates, I think now 2 years. And Saudi Arabia, I know they are having a good publication done by my colleague, Dr. Abdullah Al-Qahtani, retrospective study about using the biosimilar. I think available in Kuwait, in Oman, uh, Qatar, I think, but I don't know in Bahrain or not. But most of the Gulf they are using. And I think the first country they use biosimilar, the Dr. Danish can also give a hint about this one. It was in India. It started in 2015.
Yeah, that's
What about the medical legal?
actually that's the thing I was about to ask to Dinesh, is that if you go into the history of biosimilar, can you hear me, guys?
Yeah, we
Yes.
can hear you very nice,
Okay.
Dr. Nazim. Please.
Okay, so if you look into the history of biosimilar, because biosimilar works pretty good in the biologic suppression of autoimmune diseases in rheumatology, and the cost of treatment in rheumatology using biologics, which replace the other immunosuppressive drugs. So if you look into that history, then biosimilars is the path to go, especially in the low income and middle income countries. Now, taking that into account, if you look into the Medicare system in US, and if you look into the Middle East, particularly, I can talk about UAE, because UAE, the insurance policies are premiums are pretty much high. Now, the question might come later on that the way the Medicare is working in US, that whether they might push biosimilars to be used in patients with a similar efficacy. But however, here comes the twist. The twist is that the recent developments of dual um, anti-VEGF suppression drugs, which we have in the market right now, which has the durability, which is longer, and that is the only difference with the usual biosimilars that you will see in the other branch of medicine. Now, this has got a big impact in the low income and the middle income countries because it affects the big accessibility to service, continuation of treatment, and the economic impact on the healthcare system spending in a country who spend for their citizens. Okay. But our system is a little bit different. Our system works on privatization, so that's a typical different discussion. But the whole of the world works on social security insurance on the patients. Now, I would put this question to Dinesh first, because in 2015 was the first biosimilar ranibizumab, which was started in India, and then came from Mexico, then from Samsung, from South Korea, and then it went up. But in 2024, aflibercept has expired their patency. So it was open for biosimilars to come, and the biosimilar, I think it has already been discussed in the world that the clinical trial for phase 3 for aflibercept is also on the way, and we are soon going to get it.
Dr. Nazim, no,
Now,
there
the
is
question
some
comes to
indication
Dinesh.
already, the concept already is there, approved.
Yeah.
They are
So
started.
now I will put this question to Dinesh. Since 2015, when it came, the biosimilar in India, what is the difference of the reference drug which is available and the biosimilar? Has it increased the
Yeah.
accessibility to service and the
Can we
clinical
listen to him?
outcome?
Yeah, please.
Yeah. So,
Dr. Ben.
actually, where ranibizumab is concerned, the public health system actually gives the biosimilar. It gives, it was till now it was Razumab, and now they're giving the other ones also. In fact, now the difference is so much that the innovator drug has almost gone out of the market.
Mm.
A very small proportion of patients who are still getting the innovator drug, which is Eccentrix or Lucent is what you call in the Middle East, and we call it Eccentrix actually. So it's a huge difference because the difference in price is great. I mean, and the advantage of this is that now in smaller towns people can afford it. It's not just the people who have insurance or who are in the government sector, but even people who do not have access to any direct insurance are now they can access the drug, and the physicians will give it at a much lower cost. Similarly, there are a lot of trust institutions, charitable institutions and trust hospitals, which now give the drug at a significantly lower cost. And it's not that they don't, I mean, it's not that they're giving it as charity. They're giving it at a price which is affordable to the population and also makes economic sense for the hospitals. So that's the
as
important
well
thing.
as the clinical outcome.
And the clinical outcome is not different. So this is the important thing. But now the great change is going to come because now we have aflibercept also available as a biosimilar that's been launched. I've used it in two
Yes.
cases so far. It's called Enira. It's aflibercept biosimilar. So and that will, aflibercept had become virtually a workhorse for occult CNVMs and DMEs which were not doing well. Now, with the availability of a biosimilar of aflibercept, two things happened. First, the acceptance was very quick. You see, um, as Nazimul was telling, it came in 2015, but took a long time to get accepted by the masses of doctors. It's the doctor who has to say, go ahead and take it. So it took time for the doctors to accept it. There were initial teething troubles also. Um, Razumab went through a process where initially, after a few hundred injections, they got an episode of 4 or 5 patients who got reactions. So they had to go back to the drawing board, check what was happening. They found maybe they needed to decrease the endotoxin levels. And now, for the last many years, we've not heard any problems with ranibizumab. As a consequence, when aflibercept came into the market, there was hardly any delay. It was just picked up quickly. And that's what's happening now. Aflibercept is getting used very soon in the market.
Mm.
I think
I
if
thought
there
this is
any,
not a relevant question for the Middle East. I mean, I thought in the Middle East, issue of cost did not exist. So that's why, I mean, I was a
oh,
little surprised by the
I
attention to
think
It's
biosecurity.
Dr. Ganesh,
I
Dr.
think
Ganesh,
I
I
think it's
got you.
not about the cost. I don't think it's about the cost. It's about the clinical outcome and access to service. And there are
Outcome
people
is the
who are with
same.
insurance.
Outcome is not affected. So outcome is the same.
Yeah, exactly. That is
Yeah. So
why
Dr. Naveen,
the
I think, Dr.
biosimilar.
Naveen, if you allow me, the cost is still a problem anywhere. We will not, I mean,
yeah.
we don't, yani it is even in our area, it is in the Middle East, it is, because not everyone in the same level that they are able, even who is getting a good salary, they are not going to be able to pay, especially if he's not insured, he will not be able to take medication for 20,000 dirham because the cost is very expensive and you compare biosimilar to
Exactly.
other. Also, even for the healthcare system, they are having many things to do. They are not only concerned and and it's not possible if they will get something that can give the same effect. Why they should go to something expensive while I'm getting the same effect with another one and is with low cost? I think everywhere, does even developed or developing country, they are looking for anything that decrease the cost burden on the healthcare system. I think
Exactly. So
Egypt, they will benefit a lot. Syria, they will benefit a lot. Iraq, even Saudi Arabia. Saudi Arabia now, they are using a lot. I mean, they are using thousands of
mm,
biosimilars in compared to the previous one they are using because it is affecting the healthcare system and all countries, they are want to be smart. They don't want just to continue okay, we can use something that is not having now a biosimilar, maybe we can continue to the same. But whenever any biosimilar now, as Dr. Danishi mentioned, the ranibizumab, because it was the first to come, so it takes a little bit to accept by the doctors. But now the aflibercept doesn't take any time because people they get used about what is the biosimilar and the efficacy.
Yeah.
Um,
Actually,
we
I'll just
are
put the last
almost,
word.
yeah,
I'll just
please,
put the last word.
within a
So,
second.
not possible. So,
Yeah.
so it's not about right now the biologics. We should learn from the other branch of medicine, whether in treatment of breast cancer or any other immunosuppressive that due for tumor suppressions or in rheumatology. The same thing also happens in US for Medicaid. So that is why they were forcing to give bevacizumab because the cost is $50, then you pay for $2,000 for a reference drug. So that is where comes the public health fund. And similar, it will happen everywhere with time. Just like you get, but biologics are not generic. They are the similar drugs which works on the same function, may not be a copycat of the reference drug. It is a pharmacological outcome. So slowly, every insurance even in a developed country will look for something which is cost effective that will allow the patient to access the service and more frequently, and it's going to happen with us as well here. So what it means, biologic is going to stay, and that is will fall the bulk of the population later. Now it's a beginning phase. But the only twist in ophthalmology, the only
Okay, Dr.
twist
Nazim,
in
we don't have a time.
ophthalmology is that the new drugs which came, and that's the thing. That's my biggest question. Let us
It
go
will
Hey,
forward.
be, it will be,
Nazimul, can I make a comment regarding that? You know, the availability of biosimilar aflibercept has changed the game. Even though faricimab is a very good drug, you see the difference between faricimab and aflibercept is of 20%. There is 20% extra number of patients who manage to get greater than 12-week durability. So actually, you can give the bulk of the population aflibercept, and only those who are not responding can be shifted to faricimab if you're trying to save on costs. But if you say, I want to give the best to everybody, then you will take the most expensive way of doing it, which is to start with faricimab. And then you will not be able to utilize aflibercept very well.
Expensive does not mean gives a good outcome. I
Yeah,
will
but
defer,
so that 20, so
being a
that's what I'm saying.
clinical scientist, I will put the
So
drug
the
molecule more
20%,
important.
yeah, so the 20% extra number of patients
Yeah.
who will get a 12 weekly response, you can get that by initially starting with aflibercept and shifting to faricimab in all those patients who don't respond after the first 3, 4 injections. And
you
you'll get
mean
the best
biosimilar.
results.
You are talking biosimilar faricimab.
I'm talking of biosimilar aflibercept. And
Yeah.
then you can shift over to faricimab for those who don't do well.
But the end of
I
the
think,
story, the future is
we are
good.
long the time that we are already exceeding the time that we are supposed to be, or so we need to go to the second part of our today meeting to
Yes.
enjoy the surgical interacting and debating between our colleagues.
Dr. Mohammed, sorry,
I
there
think,
is a question in the chart from participant. Does the ranibizumab biosimilar or original have indication for CRS-CR?
yeah,
Mohammed
I
will
think
answer.
we are using so many medications just to treat the CMV if associated with central serous choroiditium. We are not treating usually the central serous choroiditinopathy, whatever. We are using in case of chronic associated with CMV. If any other of our colleagues had another opinion, just can.
I guess, Dr. Muhammad, it has the same indications as other anti-VEGFs if associated with CMV. Some chronic CSR are associated with the CMV, So if you are, this is the most solid indication. There is a CMV. Just one last question to a very quick question to Nazimul and Danish. What are the bodies who give authorization to use the biosimilars? What are the I mean,
In
how the
India,
biosimilar get
No,
approved
no,
worldwide?
it is FDA approved, Dr. Muhammad.
There
in
are so
Delhi,
many
in India,
biosimilars. Are all of them are FDA approved?
I
Yeah,
mean,
yeah.
so in India,
if you are talking about biosimilar, what we are using in UAE, this is what I know, they are having an FDA approved to be used. That's it.
yeah, but in
I don't know
India,
Of
they
about
course,
have
Muhammad
of
Awadallah.
course, yes.
Muhammad, listen one thing. The biosimilar which are in the market, first of all, they all went through a rigorous clinical trial, phase 3, and they got approved by FDA. And these biosimilars went through the same clinical trial pattern that was run through for ranibizumab. So they has been proved and then got FDA approved. This drug didn't come to the market just like that with a small pilot study. Okay, so being
So
a
this is excellent.
yeah,
This
this
is
is
excellent
excellent
answer,
one.
and this is an a very important point to deliver and message to deliver to the customers who are going to use. They
Yeah,
are. This is a very rigorous pathway of approval.
yeah,
Danish,
absolutely.
you wanted to say something.
Yes. Any last
I
comment?
was saying that in India, the biosimilars are approved by the government by an organization called the DGCI.
Mhm.
So that's the Director General of Commercial Intelligence. They do this. So all the new drugs, all the biosimilars have to be passed by them. All the data goes to them first. Some of them, I think you may be having more FDA approved drugs in UAE because we don't necessarily have all these drugs getting FDA approval. Some of them are approved by the local authorities.
Yeah, here in UAE, I think they are looking either the European or the FDA approved, and most of
Yeah.
the time for the FDA approved. Yeah.
So the European authority has approved some of these biosimilars which we have in India.
Okay. Okay, so now we can go to the second part. I think thank you very much for all this discussion regarding the biosimilar. It needs a lot of time to discuss, but we need to go to the second part. And our first speaker, it will be, I don't think Dr. Ahmed Salam is available, so we can take Dr. Ashraf
Muhammad.
Sharawi to start his talk. So we will have everyone 3 to 4 minutes presentation, then we will have a discussion about the case, or he can discuss while he is presenting, whatever it is. Dr. Ashraf, please. You can share, Dr. Ashraf.
Yes, just a minute. Can you see it now?
We see your desktop. Yeah, select the one you want to present.
Okay.
Okay.
Good afternoon, everybody. It's my pleasure to be sharing with you this session of surgical challenging webinar. The first case I'm going to present is a 75-year-old male patient who presented with sudden visual loss in the right eye following a complicated cataract surgery with massive vitreous loss and a PMMA lens implanted into the anterior chamber. The visual acuity was light perception. And you look to these still images at the start of the surgery, the inferior retina was extremely folded and the anterior chamber IOL placed in with not a very good anterior vitrectomy. we did start our surgery, and the first part of the surgery, which we have to be very careful with this detached high bullous inferior detachment, is how to place the infusion cannula. You have to be very careful to have the cannula inserted inside the vitreous cavity, and you may change the place of the cannula several times so that you are sure you can see the tip of the cannula. And we start by the vitrectomy, trying to remove all the visible vitreous and the epiretinal perforation. There was supposed a subretinal band in this area. A retinotomy was done, but nothing came out of this side of the retinotomy. After finishing with all the visible membranes and even staining of the posterior hyaloid with the kinacort, PFC was injected, trying to find a way for a retinectomy because it seems that the retina is extremely shrunken and scrambled, and I won't be able to flatten it. However, by further injection of the PFC, the retina did start to flatten, as you can see, but there was still just one fold, a radial one, down and temporal, and I did apply endodiacermy to that fold and then cut the fold with the cutter without any suction because I didn't want to have the PFC escape from the vitreous cavity. Then application of endolaser to all the sites of the retinotomy and to 180 degrees of the inferior retina. Then the PFC was exchanged for silicone oil, direct PFC silicone oil exchange. And this was the post-operative, to my surprise, post-operative appearance of the patient, like 1 week following the surgery, another mosaic of the patient. And I did follow the patient for 3 months with the silicone inside. As you can see, the retina looks to be stable and flattened. And as you can see in the inferior part of the retina, even the silicone is not full. There was an inferior part without tamponade. Again, another mosaic showing that the silicone didn't fill the inferior retina, but the retina is stable in its place. And OCT of the patient showing that the macula having some cystoid macular edema, some residual membranes, but still not detached. However, when we did follow up the patient, there was increase in the cystoid macular edema, as you can see in the right-hand picture of the OCT. The question for this case is it case is available now to remove the silicone, or still I have to wait for a little bit because of the fear of redetachment of the retina? And this is a question open for the panel. The second case, which is actually a follow-up case of a case which I did present in the
Dr.
last
Ashraf, can
IO.
we discuss the case first one?
Yeah.
So, because if the time is not enough, then we'll continue this after we take
Okay.
from each one case.
Okay.
So, is there anyone want to answer the question of Dr. Ashraf? Would you remove the silicone oil or you will wait? And also, I have one question in my mind. What are you going to do for the cystoid macular edema in this case?
Well,
Any,
a more important question in my mind, what I'm going to do with the anterior chamber IOL, which seems not to be placed in a proper way in the AC. And for sure, it's sharing to the cystoid macular edema by continuous shaving into the iris.
Mhm. Okay, any comment, Dr. Ayman? Yeah, Dr. Titiana, please go ahead.
Dr. Amin, hello.
Yeah.
Oh, yeah. Can you hear me?
Yes.
Yeah, we can hear you and we can see you. Finally, Dr. Ayman. Okay,
That's
Titiana, can you
great.
go and comment?
Yeah, thank you. And in fact, I wouldn't remove the silicone oil at this stage. I would treat the cystoid macular edema. I'll start by injecting some Kenacort posteriorly in this is a very simple procedure in the periocular space posteriorly. If this works very well, it will be fine. If it didn't work, uh, in fact, injecting intraocular steroid in the presence of silicone oil would be difficult. It would be awkward. But if it didn't work, I would, of course, remove the silicone oil and I'll put some steroid Kenacort inside the eye after removal of the silicone oil in order just to decrease the inflammatory component that's mostly causing the cystoid macular edema.
Okay, I think Dr. Ashraf asked also another question, Dr. Ayman. He is thinking that's the presence of anterior chamber IOL one of the reason, because I think putting the anterior chamber IOL, that means the
This
anterior
is a very
capsule,
good question. Yes,
anterior capsule, anterior
this
capsule already is defect,
yeah.
so you cannot put any
This
steroid like
this
Ozurdex
might
or
add to the inflammatory process in the eye. If it's the case, I would remove the anterior chamber IOL and I would suture. I put a sutured lens inside the eye. It's an easy procedure. It can be done, and it's more appropriate, and I think it will solve the problem.
Yeah, but
Do you
I
advise
think that
Dr.
this.
Ashraf to be, sorry, Dr. Ashraf, you will do it in the same time you are doing vitrectomy, or you will do it in a second
Oh, you
surgery?
can do it at when you are doing removal of the silicone oil. If the retina is stable and it's still in place, yes, you can do it at the time of removal of silicone oil. You can suture, remove the lens, and you can put a sutured lens inside the eye.
Why not to be done in the time of doing vitrectomy in the beginning?
Well, I don't advise this. I don't, already this is a complicated case. I don't want to prolong the procedure. I think I would only stay with the vitrectomy, flattening of the retina, and I will see if the retina stays in place, then I will go ahead and remove the lens and I'll put a sutured lens. This is a more appropriate way to do it.
Okay, any other opinion that what Dr. Ayman, Titiana, or Dr. Danish, Dr. Awadallah?
This is a severe case of PVR and nice surgery by Dr. Ashraf. And the inflammatory component is high, as we can see, and is rapidly progressive. What I would have done different or add to the surgery is ILM peeling will help to avoid recurrences and further membranes. And if I would advise, if the retina remains stable, to remove the silicone oil, because I believe silicone oil in general acts as a barrier that prevents rapid resolution of such cystoid macular edema. At the time of silicone oil removal, I would inject Kenacort. Of course, I wouldn't inject Ozurdex because the implant can travel anteriorly. And if the endothelial count by specular microscopy is bad, I would exchange. My preference is a Clo lens inserted on the posterior surface of the eye. It is an easy thing to put and effective. But I mean, the main issue now is to wait for some time till the retina is quite stable and there is no further membranes to come up with time.
Titiana, you want to say something?
Yeah. How much time has passed already?
Around 3 months.
3 months. Thank you for your interesting case. All of us face this PVI retina detachment. I would wait for 6 months I think it's enough for wait until the proliferative process occur, and if there are all edges of retinotomy are clear, we can remove the silicone oil with epiretinal membrane or ILM peeling. And I agree with Dr. Ayman. I would inject in subtenon space Kenacort or like this. And also I would keep this patient on steroids plus anti-glaucoma drops during a long period.
What about the IOL?
I would not touch, to be honest. If it's calm, I would not touch. The only one thing is eye pressure. But there is the pupil disintegrated. I think it helps for circulation, the humor. I think it looks as coloboma.
Yeah, I mean the pupil is irregular. The iris actually is drawn up into the wound. So I think that the anterior segment has to be looked at in a good way. Otherwise, it will share to the progressive inflammation inside the eye.
Yeah, I would not do anything if it's stable. No need to increase the damage. The
How
Can
much
you
is the
show
vision
Dr.
of,
Danish? Dr. Danish, please.
yeah, how much is the visual acuity of the patient, the BCVA at the
Actually,
moment?
the patient improved significantly to 6 over 60 or zero point 0.1 with this condition.
Yes. So,
Because as you can
I
see,
would,
the macula is okay and the
yeah.
retina is flat.
Yeah, so my first objective would be to see what is the maximum vision I can improve by improving the cystoid macular edema. And I have found that in most cases, just in giving more intensive topical steroids, you don't need systemic steroids also, just topical steroids with NSAIDs. I prefer Nepofenac for that. A combination of these two can help to decrease the CME very quickly within 4 weeks. And I would see how much is the maximum improvement with that. And depending on that only, I would consider, fiddling with the lens. Supposing the vision comes to better than 618, it makes sense to put a scleral fixated IOL later on. But supposing the vision is 636, I would rather leave it alone. Because as Dr. Tatania told us, see, it's otherwise a settled eye. You will by removing that IOL, putting a new IOL, you will again create inflammation. And especially if the vision outcome is already stuck at say maybe 636, it's not going to improve beyond that if with no CME the vision is 636.
Let me say something.
Okay, the final, because we will go to the next speaker, please. Yeah.
As I said, if the anterior segment is not the cause or is not participating in cystoid macular edema, which is mostly not because there's no vitreous and usually there's no traction, most probably the anterior chamber problem is not an issue. But as I said, and Dr. Sharawi said, if there is an evidence that the anterior segment is participating in the cystoid macular edema, I would go ahead and solve the problem by removing the IOL. And as Tatiana said, if the pressure is increased, I would remove. Or if the cornea is decompensated also, I would remove the anterior chamber IOL and I would put a sutured IOL instead. Thank you.
Thank you very much. Thank you, Dr. Ashraf, for this great case. We will go to the second speaker. If we have a time, then we can go a second run for a second case from anyone available. Okay, so Dr. Ayman Midanat now is you're going to present the case, one case.
Yes. Let me say share and want to look at the PowerPoint.
Mhm.
Go to search, it will be there.
I'm just trying to go to our PowerPoint with.
Open the
You
PowerPoint.
already
Yeah,
open it,
yeah,
Dr.
that
Nazim.
one.
Yeah, just you open whatever you open it before. You share it. It will
And
be
go
Wait.
to the file. Go to the file.
Yes, wait. We're going to the MEOM meeting. This
MEOM
is,
meeting. Yeah.
here we are.
Yes.
All right.
Alhamdulillah.
Yes.
Okay. Oh, fine. Can you see my presentation?
Yes, please. Go ahead.
Yes, this is a 42-year-old male patient presented to our clinic, to our center with poor vision in his left eye for more than 1 year. He has right phaco with IOL followed by left complicated phaco with no IOL, which was followed by retinal detachment somewhere else. The patient has history of ankylosing spondylitis and chronic uveitis. The retinal detachment was neglected with severe epiretinal, subretinal PVR, and very low intraocular pressure. The pressure was 1. Vision in the right eye was 1, and vision in the left eye was perception of light. This is the fundus view. You can see the retinal detachment, subtotal detachment with only sparing small quadrant in the superior-temporal part. The PVR, especially in the lower part of the retina, you can see the epiretinal and subretinal fibrosis and the hazy media. After discussion with the patient about the Gardner prognosis, we decided a buccal PPV for this case. We started the case, and you can see that there is the vitreous is sticky with some PVR in front of the retina, and you can see the subretinal fibrosis over here. And now we are trimming the vitreous as far as we can, and you can look at the PVR. It's tightly adherent to the retina. The retina looks very stiff, it's not moving. And we tried now to remove the retinal membrane from the posterior pool after staining with brilliant blue. It was not that easy, so we decided to put heavy liquid and we started peeling the epiretinal membrane over the macula under the heavy liquid. You can see that the retina is very stiff, is not moving, and the epiretinal membrane with the underlying ILM are very adherent to the underlying retina. This was a very delicate procedure because we are working over the macular area and over the fovea. After removal of this epiretinal membrane and ILM from the posterior pool, we went to the periphery. You can see the PVR is very adherent, is very thick, and it's multi-layered, and definitely the retina looks very shortened, mostly because there was a contraction at the vitreous base with adhesions, and this also was the cause of the low pressure. Now, after tightening of the buccal, the retina did not flatten. We tried to remove also as much as we can from the PVR at the periphery. It was not that easy. The retina was stiff, and the PVR was so adherent and it was multi-layered. You can see that we are removing this layer of PVR, and underneath this layer there was another layer of PVR, as I'm going to show you now. This is the other layer of PVR under the first layer, and you can see the retina is still stiff. You are using the tangential force. Now an iatrogenic hole was created, and you can see that the retina is very stiff due to the counter action forces. Now, at this stage, we decided to do a retinectomy in order to release this traction. We did a confluent diathermy to stop bleeding and do a proper hemostasis, and we cut the retina using the Occutome 360. Now the retina is released, and we did 3 layers of laser treatment at the edge of the retina. This is the usual thing when we do a retinectomy. And after that, we removed the heavy liquid from the posterior pool. And this is the last bit of the heavy liquid removed. And the eye was filled with silicone oil. This is the fundus post-operatively, 6 weeks after surgery. The vision improved to only half meter with correction, and the intraocular pressure was 10 millimeter mercury. Now the problem is, would you remove the silicone oil for this patient? This patient is aphakic. Would you go ahead and put an IOL, or would you like to keep the silicone oil forever in such cases?
Okay, we can move this question starting with Dr. Ashraf. Ashraf, I think
Yeah.
now
I think that this case opened a lot of discussion. The first of all, for me, what's the extent of the retinectomy you go for? Because as you had shown us in the preoperative picture, that the upper nasal or upper temporal, I don't remember, is already attached. So it's not shortened in this area. The question, you did go for 360-degree retinectomy.
This is a
Why
very
you didn't
this
shorten?
this is a very good question, Dr. Ashraf. In fact, yes, it was a small triangle at the superior temporal part that was attached. But when we started doing the retinectomy, in fact, when you look at the vitreous base, there was a contraction of the vitreous base 360. Even when the superior temporal quadrant was attached. So the question was to leave this bit attached to the retina. In fact, we decided to remove it because we thought if we kept it, it can be a source of PVR to the retina and would complicate the case later on. And because there was a 360 contraction of the vitreous base, we thought that it's wise to do a 360 retinectomy in such a case.
The other point which you should insist, for me at least, I should insist on it, is that direct PFC silicone exchange is the best way to go, because some surgeon would think about PFC air exchange first and followed by silicone oil injection. Usually this ends
This is
in
this
so
is
many
only
times of
this
slippage.
is also a very good question, Dr. Ashraf. In fact, because of the short of the time, at the time of the surgery, we did kept the heavy liquid for 5 days, and the patient slept on his back just to make sure that the retina is flattening completely. Then we went back after 5 days, we removed the heavy liquid, and we replaced it with silicone oil. This was the way that we did the case.
Okay.
Dr. Ayman, Dr. Ayman, I have a question for you.
Yes.
Did you initially put in PFCL to see whether it was flattening, whether the retina was flat?
Yes, of course. As you noticed, when we were peeling the epiretinal membrane for posterior pool, I injected heavy liquid before starting the peeling, because when I start peeling it without heavy liquid, it was not that easy. So
Yeah, so
after staining, we did put heavy liquid at the start. Yes, there
because
was the heavy liquid, and the retina was not flattened.
because I was seeing that when you were doing the ILM peeling, you didn't have the heavy liquid at that time. It would have
No,
helped.
I'll show it to you. If I can go back to if you like, to the
already
Because that
video.
could have
done.
improved that.
It's
I
okay.
can go back to the video, and I'll show you that. Yeah. Look, you can see the edge of the heavy liquid here. I put heavy liquid, and the peeling was done under heavy liquid.
So
You
if
can
you
see
yeah,
that. You
okay.
can see that it's been done under heavy liquid. Yes.
Okay, so because and the other thing you could have considered, instead of retinectomy in first go, I mean, which we are now doing in these bad cases, you put the heavy liquid all the way, and leave it on heavy liquid for the next 10 days or so. So very often that shortening gets better. And then you can go ahead and do a second surgery in which this comes off, because you had already done the peeling, so you'd already decreased the shortening to quite an extent. So have you considered that?
Absolutely, you're absolutely right. You can do this in some difficult cases. This case, the retinal detachment was for more than 1 year. We did put a buckle and we did put the heavy liquid, and the heavy liquid was reaching more above the level of the buckle, and the retina was not attached. There
Okay.
was still the retina was shortened, and even at that stage, we could not just leave it. We had to do the retinectomy because, as I told you, there was a significant contraction at the vitreous base causing shortening of the retina. So we were convinced that this retina would not flatten without retinectomy. But
It is a
absolutely, you're
challenging
right.
situation.
If the PVR was not that mature, yes, your maneuver would work sometimes. Yes, I totally agree.
Tatiana, if you have any
Excellent.
comments before.
Yes.
Oh, sorry, Abdullah.
Yeah,
Sorry,
yeah,
I don't.
Mohammed, continue.
Dr.
Dr.
Abdullah,
Mohammed,
تفضل.
continue.
Thank you, Tatiana. Excellent case, Dr. Ayman. It
you.
stimulates a lot of debate. And my first point is this is an excellent case indication for intravitreal methotrexate, the new trend that prevents recurrence, because the risk in this case is recurrence because of further membranes. And methotrexate, whether put on the infusion during surgery or injection, intravitreal injections after post-operatively, would decrease, I think, the risk of PVR post-operatively and recurrence. Also, I commend you because you resorted to retinectomy as a last chance after exhausting all means of peeling the membranes of the epiretina, which because if we give some time and be patient to remove all membranes, it's better than to do such extensive retinectomy. But I mean, it's an excellent approach. And my concern only with the buccal, that if you do the retinectomy that's further posterior the buccal, this carries some risk of slippage of the retina. This is only the drawback, but I mean, the buccal is good if you were not intending to do such extensive retinectomy. Just the risk of the slippage of the retina because of the buccal. If the edge comes at the retinal, the edge of the retinectomy comes at the posterior edge of the buccal. Thank you,
Very
Dr.
much,
Ayman.
Dr. Mohammed. Very, an excellent question. In fact, the buckle was removed after retinectomy. We didn't keep the buckle. At the end of the
Excellent.
surgery, yes, we removed the buckle. This is a very excellent point. Yes, the buckle was removed.
Tatiana?
And regarding
Thank you. It's an
methotrexate,
excellent case, Dr. Ayman. A lot of
thank you.
learning and teaching from this.
Thank you. I mean, regarding methotrexate, I don't have any experience in methotrexate, but what I did, in fact, is I made sure to remove all the epiretinal membrane from the posterior pool, just to avoid fibrosis and retinal contracture post-operatively.
Excellent, Dr. Ayman.
Thank you very much.
Thank
Tatiana,
you
you
so
have anything?
The same comment, to be honest. And I appreciate your wise step approach that you did not do 360 retinotomy from the very beginning, even if you felt that it will finish with this one. You did everything to save the periphery. And I also had a question about blood supply and slippage risk of tightened buckle, but you answered.
Thank you very
Thank you.
much, Tatiana.
Okay, thank you very much, Dr. Ayman. Thank you for all. Now we can move to our Dr. Danish, please.
Yeah. Okay.
I think there are two questions on the Q&A.
Okay.
Can we check that?
Dr. Ibrahim, what is the place of scleral buckling here? Okay, Dr. Ayman, meanwhile, Dr. What is
I
the
think
place?
this was for Dr. Ashraf.
Ayman. No, this is the first one. What is the place of scleral buckling here, Dr. Ayman?
Yes, in cases of severe PVR, in fact, scleral buckling would help to flatten the retina by decreasing the anteroposterior diameter of the globe. So, in every case of severe PVR, I used to put a scleral buckling 240 band at the retinal periphery. But in this case, in fact, when we decided to do a retinectomy, there was no role to keep the buckle, so it was removed at the end of the surgery.
Can you give also a very short, please, about the following? Any role of heavy silicone oil like dinithiron in such cases with intense BVR?
In fact, yes, usually the PVR is mostly found in the inferior retina in these cases. And if you are doing an inferior retinectomy, the densiron or heavy silicone oil might have a role. But this, in cases of 360 retinectomy, I don't think the densiron has any role in such cases.
Okay. Dr. Nadeem, also there is a small part of this question. Is it available in the GCC?
Yeah, the insulin is available in this GCC.
Okay, thank you very much. So we can move, Dr. Danish, sorry to keep you waiting, please.
Basically, I'm discussing a diabetic vitrectomy where there was a densely adherent epiretinal membrane with traction detachment, which covered the entire posterior pole. Now, I believe that in any major diabetic vitrectomy, you have to do four different things. You do reconnaissance, which is intelligence gathering, the initial forays, you assess your enemy, which is the TRD. Then you formulate your strategy, but you must be nimble in execution. So let's see how we go ahead. So first you assess where are your peripheral openings. Can you see any space between the membrane and the retina? Check up all the entire retina. Check up the intensity of that adhesion and then see the potential stalks. I normally use a 25G MVR to pick off the membrane from the retinal surface and create a wedge for insertion of the cutter. And then I use the blunt edge of the cutter to lift the adjacent membranes off the retinal surface safely. And if I see any sign of bleeding underneath a membrane which I can't see clearly, I will desist and go to another site. The other important thing is you can go from in to out, or you can go from out to in, but you move radially from periphery to the disc or from the disc to the periphery in multiple directions, looking for areas where the adhesions are least sticky. So this is just to show you, like in this case, I went first from here, found it was getting stuck, then came here, then went around, and then finally went downwards radially in different directions. We'll see this now in this video. So this is a one-eyed patient with a, this is a one-eyed patient with with this kind of picture of a total RD, which is tractional, and I'm now trying to figure out where are the membranes and where I can get an edge in this membrane. So this is what I've looked at. We can already shown you this. I've tried above, then I go from the side. So you see this, I found an edge over here. I'm extending that edge with this cutter. It's an old detachment. You can see the vessels are sclerosed. And here I go towards the disc. But then I find a bleed over there right at the disc. I decided to leave this alone for the moment, go from the inferonasal area, extend that, and you can see that there are multiple areas where there are these stalks which are attached to the membrane. You see this over here. So trim around them so that, and create space around those. Make sure that you don't let any bleeding accumulate. If you let bleeding accumulate, you get into trouble. And I did that, and I lost almost an hour in the process, which you're not going to see over here because of the fact that this is only a 4-minute video. And this is this bleeding at the disc, which we did clean. And left the last bit so that it should not bleed again. And then now we're separating it out over here. You can see it's a very dense membrane. Tried to see if I can come from the periphery, but found that I wasn't getting an edge. And now I shifted to bimanual surgery. And incidentally, I think most of us make the mistake of shifting too late to bimanual surgery. This is the situation where bimanual can make your life very easily. I have used the scissors here as a shearing instrument. You see this? I hold the forceps and I use the scissors as a shearing instrument to separate between the retina and the membrane. And once I've created the space, then I cut it out with the cutter. The same thing going on here. You can see it's a very dense membrane. The macula is fairly healthy, actually. Now again, I'm holding with the forceps, using the scissors as a shearing instrument first, creating the space, and then extending my incision. And it's a game of patience. You need to spend time, make sure you don't create breaks. In this case, we got away without creating a break all the way to the end. There was only one break, which you're not seeing here. And now you see this, we're separating out this membrane, then trimming it again. Again, you have to meticulously remove these membranes and put PFCL to stabilize the retina at the posterior pole. Now increasing that, you see the membranes have become clear. Now at this stage, don't think the work is done. The periphery must be checked. Any adhesions in the periphery must be completely cleared off. Your vitreous must be cleared off as far anteriorly as possible, shaving close to the posterior vitreous face and ahead of that also. And then this was shifted to silicone oil. Now, the important thing is to find the plane of separation, identify the vascular stalks and the segments around them, avoid creating bleeding points, and avoid the spread of bleeding. So if you've got a bleed, clean it, leave the last part so that it shouldn't start bleeding again. Don't dislodge the clots, and use diathermy only after you've removed the traction from an area. And if you have success, patience will follow. If you have patience, success will follow. Thank you. I want to dedicate this to my guru, Professor Tiwari, he was the one who prodded me to make videos of my work, which I wasn't initially doing. Thank you very much. He is no longer there with us. This patient got 636 vision at the end of surgery.
Ramesh, thank you very much, Dr. Danish, for this excellent case. I think I will forward the question this time, Titiana the first, then Dr. Audallah. Any comment, Titiana, please, or questions?
Yeah, every PDR case with tractional tabletop detachment is challenging. It's impossible to know how much bleeding it will. The only one thing we have to try to prevent a lot of bleeding, it's making anti-VEGF 3-5 days before. And then all our tools should be used, segmentation and in-block. Thank you for your great presentation. I would like to ask you, how often do you use PFCL, or don't you try not to use it, to avoid it?
Yeah. So if there's this detachment there at the posterior pole, then I will try to stabilize the retina at that time. But if it's only a traction detachment and the retina is overall attached, then I will avoid PFCL.
Yeah.
Dr. Awadallah.
Excellent case, Dr. Denish, and an excellent demonstration of with a tough case. Just my couple of questions. The first, did you remove the lens? Did you do phaco? Because such
No,
cases
actually,
will.
in this particular surgery, I didn't. It was
This is
done
what I
later
noticed,
on when
because
we
I
removed the
noticed there
silicone
is a
oil.
lens, and for
Yes,
me,
so
I
that
would
lens
have
was
done
clear. He was
definitely.
one-eyed, and I didn't want to remove the lens.
Definitely for me, I would remove. I would do phaco because I need to do a very good shaving of the periphery. Otherwise, he might get another proliferation. Also, I would look for, after removal, I would look for some vitreous cases or something, because still such tough cases, you might have an area with the left some vitreous. So, however, and I like you shifting to bimanual, and your comment that definitely if I have the bimanual nearby, so I would start with the bimanual, such the tough one of the toughest cases. Thank you for
Yeah,
demonstration
so
of this.
they're excellent comments, and I'd like to reply to them because, some of the reasons why I do things this way. I leave if the lens is clear, I don't touch it in the first surgery. I know there is a possibility that I will touch the lens somewhere. I'm not bothered because I know I'm going to use silicone oil. And with the silicone oil, the cataract will not progress as it would progress with air or gas. So I will do my complete surgery, not worry if the lens gets touched somewhere. Complete, as you said, complete the vitrectomy all the way to the periphery. But the important thing is I make sure that now, if I've not done the lens removal, the cornea doesn't get affected. So the cornea stays absolutely clear. The otherwise sometimes you can end up with folds in the cornea especially in a long surgery. This surgery I got stuck, it bled. It took me 4 hours. Now, if I had done the cataract removal, I would have had a hazy media and I wouldn't have been able to complete the surgery. Because the lens was there, I was able to complete the surgery. Cornea stayed clear till the end. I only needed to do epithelial debridement. The important thing was to complete the vitrectomy. The tendency is to think you've cleaned the big membrane in the center and this is it. It's not. It's only half the job. You still have to
Yes.
make sure that all the small stalks between the vitreous and the periphery are removed at the periphery. If you don't remove those, you get a detachment later on. So
Right.
that is the critical part. That clean the vitreous completely from the periphery, and then make sure you laser after that completely. So this is, and we removed the oil in this case, I think after 2 months or so, along with the cataract surgery, and that's finally this is one-eyed patient getting 636, 624 vision was a very big thing.
Excellent.
Dr. Nazim, you have a comment, please.
Hello?
Dr. Nazim?
Oh, yeah. So, what I want to say, it's a good case, but there was a question that which came from the audience. So I wanted to combine my comment with the question from the audience. Is that would you like to use an anti-VEGF? First
Yes,
of
it
all,
was used. Yes.
oh, it was used. So
Yeah, it was used 2 days before.
yeah,
The usual standard operating procedure is to give an anti-VEGF 2 to 3 days before I go for the surgery. I don't
exactly.
wait more than 3 days because I'm scared. I once had a crunch phenomenon with a combined rhegmatogenous traction detachment developing 5 days later. The surgery was
Exactly.
delayed by 5 days.
So,
When I went in 5 days later, he also got a rhegmatogenous component. So
okay,
my limit is 2 to 3 days,
okay.
and it's
So
fixed.
So
I will not take up the patient.
you give a biosimilar, Dr. Denish,
Yes, I give ranibizumab. I give
yeah.
ranibizumab.
So
Yes.
I have a
When I give a
different.
biosimilar, it's cheaper.
biosimilar.
So
Just to combine medical and surgical, because of
Yeah.
Dr. Amri will be happy.
Yeah.
No, why I would be
so
happier? Oh,
yeah, wait.
Muhammad,
So
Muhammad, can you hear me? Hello.
Yes, we can hear you, Dr. Ayman. Yes.
My question to Danish, an excellent case. In fact, we deal with a lot of such cases in our part of the world. I've noticed that you haven't done laser at the end of your surgery.
Yeah, I completed the laser.
Have you done laser treatment to the case, PRP?
Yes.
You done, because
It was
we
completed.
didn't.
I had to finish the surgery in 5 minutes to show,
Yeah,
so I
but
have not shown the laser part, which is
yeah,
straightforward.
this is, I was wondering because the
Yeah,
laser, it's very
yes,
important part.
exactly. Yeah,
We
yeah.
need the last
Thank you.
comment. If there is any comment from Dr. Ashraf, you have any comment, Dr. Ashraf, please? Or Dr. Ashraf Sharawi?
He wrote that he has some urgent case. And
Okay.
Okay,
Okay, I didn't
can I
notice.
Actually-
complete the comment?
Yeah, please go ahead, Dr.
Yeah.
Nazim.
So I didn't complete it.
Sorry.
Yeah. So first of all, I want to say that the kind of case which you presented, Dr. Dinesh, so I don't inject. First of all, I believe I am a hardcore surgeon. So I believe if you go on the second membrane below, the whole membrane comes out. But take that off. If you use a spatula, if you use a spatula instead of using a forceps and scissors, and you still have a spatula. Before I used to use a spatula in 20 gauge. The whole membrane from the posterior pole up to the mid equator, you can remove it very well if you use a spatula. Now it is available even in 25 gauge. So if you do that, instead of using the scissors, you can easily use bimanually. You use the spatula to remove those adhesions and intermittently use the PFO to settle it down so you have a third hand for traction. That is the art of surgery. So as you're doing it, once you reach the mid equator, there's no more proliferations in diabetics. So that is where the next problem starts, is the adhesiveness of the vitreous. Okay, and that's where you cannot peel off the posterior vitreous up to the periphery. That's where you need the trimming. So this is a basic understanding of understanding the posterior vitreous disease of a diabetic. And this is where the people make mistake, they pull, it could tear and all the stuff. And then again, as you reach to the periphery, then you need to decide. In diabetics, you don't need a buckle. But if it is something else that was just shown by Dr. Ayman, which was the posterior, which a post-inflammatory vitreous. In Dr. Ayman's case, the post-inflammatory vitreous are sticky. So he intend to put a buckle. So there you cannot pull the membrane. Even if you pull the vitreous, it's sticky. You just need to trim it. And as a result of which, he did a relaxing retinectomy, and that which the superior part stayed, because the inflammatory process mostly will fall on the inferior vitreous. So it is very important to understand in you post-uveitis and diabetics, the understanding of the vitreous. And diabetics is a posterior vitreous disease. Remember how the proliferation goes to the posterior vitreous and goes into the intragel. And that is how it works. And people wrongly think give injection, it works, but it may cause a crunching effect. And that is how you should understand when to inject pre-op, or you don't inject and do a good posterior vitreous surgery. And this is all my comment.
Yes,
And I
those
want to say,
Again,
are very
yeah,
important
I think,
comments. Thank you very much. Very important comments.
but
And I think,
Dr. Danish, do it very fast. We are in late of
yeah,
time.
so I'll just tell you, I use the spatula too, but you have to be a little careful with the spatula in a retina which is thin. Like this was an old traction detachment. And here there's a risk that at every point where there is that knuckle, it can either bleed or it can break. So I wanted to make sure either I delaminate it or I segment around it, which is what was done for every one of those, those nails. The second important thing is you're absolutely right. basic vasoproliferation, the membrane, is all at the posterior pole. But the anterior vitreous is, as you said, sticky. If you do not trim it completely, later on it forms traction with the posterior vitreous base, and there you get a traction detachment. And that will result in a long-term compromise of your result. So therefore, trim that vitreous completely and laser all the way as much anteriorly as possible right up to the aura. So these are the two things which will make sure that doesn't happen. A lot of the rebleeds that you get happen because the laser hasn't been completed. So you're absolutely right. And as far as the crunch phenomenon is concerned, believe me, it does not happen in 2 days. So for me, the deadline for that is third day surgery has to be done.
So
Thank
you
you
are
very
not
much.
doing, you are not injecting Nazimul because of the crunch, or what is the reason?
No, but
You
I
do not
don't. I
inject.
don't. No, 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 no.
Why are the what are the reasons?
No, no, not reasons. I don't inject only. Till now, I've injected twice in my 26 years. So what I do even is that I'm operating next week, actually, somebody which has got active proliferations. I'm very comfortable. So the trick is, the art of surgery is to understand the anatomy and the physiology of the pathology. Mark my
Yes,
words.
right.
So
I-
I go from the periphery in diabetics. So I go below. The other day, I was doing a high myopic epiretinal membrane with cystic edema with the foveal schisis. The vitreous was everywhere, but I still believe the posterior schisis vitreous was attached. She was -8. I peeled the vitreous from the hyaloid on the optic disc and it came out. So the anatomy and the pathophysiology of the vitreous is very important to understand in every disease, especially in diabetics. Diabetics is a vitreous disease actually. Many times you get recurrent hemorrhage, you remove the vitreous, your hemorrhage goes off because there is no scaffold for it to grow.
Right.
Dr. Muhammad, just one small comment.
Okay, please, the final, please.
Yes. An attempt to remove the epiretinal membrane from posterior pool by a forceps or by a spatula, I totally agree with Danish. Sometimes if you are doing this, you will end up with bleeding. The best way to do it is to use the scissors and be careful when you are doing this. This is number one. Number two, I started doing ILM peeling in such cases of severe PVR or severe membrane proliferation in diabetics. And I found this will give us best results with less fibrosis postoperatively. So I do peel the ILM from the posterior pool in every case with severe PVR.
Thank you very much. I think we need to move to the last but not the least, Dr. Titiana case, please.
Thank you so much, Dr. Mohammed.
Yeah,
I'm
please.
the last. Okay.
Yeah. Because your name is T, that's what I will do. It's an alphabetic.
Okay.
What I will do.
Yeah, I have prepared
You can
not
say
so
your
complex.
name, then I will put you in the first. It's the only options.
Thank you. I have prepared not so difficult and challenging case, as I saw that I'm the last in this row. So my topic is about full thickness macular hole with coexisted atypical epiretinal proliferation. And I want to pay your attention on this specific topic. So I don't have any disclosure. I just remind the picture in the CT that this is the amorphous material over the retina surface. Often we can see it as a highly reflective line, and within this line there is the tissue of epiretinal proliferation. And just a second. This is several points that epiretinal proliferation has only recently become widely known because of a lot of imaging with OCT. And it was found as the tissue with epiretinal membrane associated with lamellar macular hole. And there are several theories of its origin. That it may happen originates from vitreous or as a Muller cell-driven process and from retinal pigment epithelium because there is a white yellow color that may be the pigment of Muller cells or pigment epithelium. And I would like to share with you several cases. All of them has the same features. This is the patient vitrectomized before patient with he had a retinal membrane before, and now he has full thickness macular hole with this yellowish tissue. You see that there is the tissue that it's unlike as routine epiretinal membrane. So this tissue has strong adhesion on the borders of the edge of macular hole, and we keep this epiretinal proliferation. We do not touch, we do not remove this tissue, and it works as a reparative tissue biological component usually. I did 360 ILM peeling, and the macular hole was closed. Another case, the same, the patient has yellow tissue, old standing macular hole, and we started with identifying this yellow membrane. It's amorphous. It's not so easy, but at the same time not so difficult to find the edge and to peel gently. And this tissue does not stain. Only ILM can stain with blue color. Then ILM peeling is done. And again, you see there is the term in the article of our Korean colleagues as a perifoveal crown. You see this crown with remnants of tissue that adherent to the borders, to the margins of the hole. We kept it, did not remove, and it works as reparative material. So this supports the concept that epiretinal proliferation may serve as biological scaffold. And the last case, the same idea, but I started to remove ILM first because the epiretinal proliferation located on it, to remove the underlying tissue at first. And you see that there is no stain near around the macular hole. Only so we should start quite far to find the real ILM without this tissue. Do 360 ILM peeling, cut the remnants, leave the edges of this membrane and air tamponade. This hole also was closed. So several points as a conclusion that surgery of epiretinal membrane, epiretinal proliferation associated with macular hole has specific aspects, and the presence of fixed perifoveal border of epiretinal tissue is an intraoperative feature, and preservation of this border of proliferation contributes to the closure of macular hole without additional mechanical manipulation or using biological adjuvants. Thank you for your attention.
Thank you very much, Tatiana, for these cases you present. If there is any question, yeah, Dr. Awdallah, I think you are raising hand. Please go ahead.
Yes, very nice case and very nice presentation. And about the what we call lip, the lamellar hole associated proliferation. And these were discovered, and also now not only in lamellar macular hole, but it is also in the full thickness macular hole, where it is called MIP. And characteristically, we have this hyperreflective line seen on the preoperative OCT. And thanks for bringing the issue of not removing this. Otherwise, we can utilize this tissue as a scaffold that bridges the edges of the macular hole and help closure rather than removing this tissue. The only thing that reports and papers about lip and MIP are associated with the degenerative types of lamellar macular hole. And this usually carries a lower visual prognosis, because the degenerative type of the holes usually behave visually in a less favorable after surgery. But again, it's a very nice, elegant surgery, and thank you for bringing up and raising up this issue. Thank you.
Thank you so much. Really, visual acuity depends on the timing of this macular hole, and usually it's all standing. Here in Saudi Arabia, I faced several cases with 5 years existing macular hole, but all of them are closed. Even I'm surprised. Sometimes there are so few material of this retinal proliferation on the border, but it closed. According to literature, it has not so good anatomical success, but I found that it's 100% anatomical success, not because of me, because of this kind of tissue. It has Müller cells. I think this theory is right. It's combined theory, I think, but really we put ILM flap to proliferate these Müller cells. But now it has, this tissue has it. So it helps us. It's like a helpful.
Yeah, as you mentioned, the most important theory is that they come actually from inside the hole in a reparative process,
Yeah.
and it includes this pigment, the yellowish pigment of the
Yellow,
macula
yes.
that come from inside outside. This is, I think, the most plausible
Exactly.
theory.
Yeah. This one, Awadallah, you have told something very important. See, I'm not interested in what the surgical outcome is. I'm more interested in pathophysiology and the basic science which goes in what Tatiana has said. Actually, she has said something good. It is a lipofuscin pigment, okay? And
Exactly.
lipofuscin pigments comes from those, if you do a fundus autofluorescence, you'll find those lipofuscin pigments there. Where does this come from? See, this comes from the RPE, okay?
Right.
So it is interesting to know. Actually, you give me an insight to take those tissue now to send it to my lab to study it if I see a macular hole next time, you know?
Actually,
So
actually,
how
there are papers about this. They studied
exactly?
this
So this is what I'm
material.
saying. She has pushed it to understand that to how these cells with those lipofuscins is a very important part in maintaining the health of the RP cells. Okay. And you know that that is how the fundus autofluorescence works in terms of survivals of the RP cells. So she told something very important. So I think you have incited some good thinking into, at least to me.
Yeah, but the problem, once you see Nazim, those tissue coming out, this means that there was a degeneration inside, and
At
it is a
first.
That pulled it up.
mechanism. So this
That
is a
pulled it up.
degenerative. That's why the prognosis of surgery visually is less favorable than the tractional type, where you do not see the leb or mib. This is the point.
Yeah. Yeah,
Tiana,
this is a point. And for me, it is like, how can I look into it to next to study it?
yeah.
Okay,
You
can
know?
we
But
have any final
Dr.
comments, please?
Dr. Muhammad.
Yes, please, Dr. Ayman, and then Dr. Danish, before we go to
Yeah.
the last point.
Tatiana, this was an elegant surgery, beautiful surgery. Thank you very much. In fact, we don't used to see a lot of epiretinal membrane formation in cases of full thickness macular hole, but we used to see this in lamellar macular hole or lamellar macular hole going on to full thickness hole. The interesting thing about these cases, usually peeling the ILM is really difficult, because in such cases with the proliferation, the ILM is brittle and is so adherent to the underlying tissue. But in the cases that's been shown by Tatiana, that was not the case. So it's really interesting. And if I were you, Tatiana, I would publish these cases, because I think this is very unusual.
Actually,
Thank you.
Dr. Ayman,
Thank you very much.
Dr. Ayman, you use this tissue and you insert this tissue
Embedding.
inside. It is
Embedded, yes.
described
But
in literature that
usually,
you put this tissue inside,
yeah,
instead of the
absolutely.
ILM.
But usually, our experience, and I have some experience in such cases with macular holes. Usually, when there is epiretinal membrane formation, it's not easy to peel the ILM. Uh, the cases that been shown with Tatiana is different from what I used to see. In fact, the ILM was peeled easily in such cases, and I think this is different from the cases that we used to see with lamellar macular hole that proceed to full thickness hole.
Okay, anyway, thank
Dr.
you very much.
Tatiana, I just wanted to ask
Thank
one
you, Dr.
question,
Ayman.
one
Yeah,
comment.
I
The
was
question,
planning to give you the talk, yeah, Dr. Danish,
yeah,
the
just
final
I
one.
wanted to
Only.
know which dye did you use, because it's heavier than, seems to be heavier than water, no? Because you didn't
Yes,
do it
it's
under air.
membrane blue by Dork.
Oh,
It's
okay. Because
membrane
so you do it under fluid only, no?
only
Was it
fluid,
under
yes.
air?
Even I do not close the infusion line. It's done by system when I inject.
Yeah, under fluid.
Under fluid.
Under fluid. Okay.
Danish, you add
The
to
second
it
comment I wanted
10%
to,
dextrose water. Add 10%
yes,
dextrose water to the dye. It will stick even if you don't
yes.
close the
Yes, so that because then it's heavier. This
yes,
the one
yes.
we don't. The second was a comment. In fact, in 30% of cases of macular hole, if you know, you will find when you do the staining around the hole, it doesn't stain well. That area which doesn't stain well is what Titania showed as that epiretinal proliferation. In fact, if you and I use this routinely, if you use a diamond dusted to go around that, you'll find the membrane comes off, and you can actually separate it out, and then actually staining is easier. Then it stains till the edge of the macular hole. So far, I've actually been removing most of that proliferation. I don't leave the proliferation. If you didn't bother to remove it, you would actually end up, part of that proliferation would come out when you remove the ILM, and a little bit would be left, which, as you showed, helped to close the hole better. So maybe in future, I will not make any attempt to remove that last bit and leave it on the hole itself, as you suggested. Thank you very much.
I would suggest not to use the diamond dusted scraper.
Of course, yes.
Yeah, because I have also published the paper which shows the macular abnormality of the inner retinal changes, and with the foveal ERG, which shows there's a decrease in the function. So it is good you can initiate the pill using a 25 gauge finesse loop and use whatever you use. I use a disposable Grishaver ILM forceps to complete the pill. So
No, not for the peel. I'm not talking about, I was talking about this proliferation.
This
If you just
proliferation, yes.
if you just gently go in that area, it comes off. That membrane, and then you can,
but
you
don't
can
use
just,
the diamond dusted one.
yes,
The
okay, but
problem,
otherwise it doesn't come out easily.
The
Yeah, I
problem,
agree
Dr.
with
Denish,
you.
if you
There is
if
there is
you
a lot of
remove this,
controversy about using the diamond dusted forceps, diamond dusted scratcher.
Yeah,
the
most of the
problem,
people have
Dr.
given up using that.
Yes. Yeah.
The problem,
Anyway,
Dr. Denish, if
it's
you remove this yellow crown, yellowish crown that Tatiana, it induces damage to the edge of the hole because it comes from inside and it is firmly attached to the edge. So if you insist on removing
Don't
this yellowish
remove, don't
crown,
remove. I think Tatiana gave
yeah,
me a lot of thing to think about this one
But Tatiana,
because
I
there
think
is
you should not be
lipofusion there.
the last one. Should be the first one. They will discuss up to 2 hours. Come on. Anyway, it was very nice and very
Thank you
interesting
so
and
much.
very good discussions. But I don't want you to leave. So we are exceeding and around by around 25 minutes than what is suggested. But anyway, it was very fruitful discussion and yeah, and interesting. We have another two things. We will select now the winners of this from the attendees who is going to get free registration and accommodation in 8 MEOM. One. Then we will have two who's going to get a free registration. So start, okay, please.
Who will start?
He is doing now. He is
Who?
taking Abdullah.
Abdullah?
Yeah.
Abdullah,
Okay.
don't be biased.
You know, there is no bias. It will come by itself.
Oh, Walid.
Walid Qamhi from Lebanon. So Walid, it is a great that you are here with us, our friends, I think. So he is going to get a free registration and accommodation for the 8 MEOM conference. Next.
Congrats.
Why my name is not there?
No, a speaker not involved.
I will give you free registration.
So Ludmila Khamilik, she will get a free
Miluk.
registration. Huh?
Emelik.
Miluk.
Okay, this is
come on.
Melik?
okay. You can read it, Titiana.
Congrats. Ludmila Khmeluk. Congrats. So
Okay,
the free participation and
they will
registration.
receive. By the way, they will receive an email within 1 or 2 days about all these things. Okay, next,
Great.
Abdullah.
Oh my God.
Okay, Hamza Krifa. Hamza also he is from Tunisia, as I know, and he is part of the MEOM Academy, young ophthalmologist. Congratulations, Dr. Hamza. Also, he will get a free registration for the conference. So, and the last, I would like to thank you all. It was a great. We will share with you this only small video, please. Then we can conclude our sessions. And I would like also to invite all who is those with us today. We will have another meeting in 9 of May, another sessions. And we will announce that soon. Okay, Abdullah, can you? Thank you very much for all our speakers and for our attendees for attending this. Really, I was enjoying this meeting and these discussions as usual. Thank you, Abdullah. Thank you, Dr.
Thank
Danish,
you,
Dr.
Dr.
Hussein,
Muhammad.
Diana, Dr. Ashraf Sha'rawi, and also Dr. Ayman Midanat, and also Abdullah from BL Event, and to all our attendees for this meeting. And we hope to see you, inshallah, very soon in the next meeting. Also, I would like to welcome you to Dubai, what we call it in Arabic, Dubai Danat Dunya. So it is one of the best area and safest area in the world. And thank you very much, and see you soon.
Thank
Good
you
luck.
so
Dr.
much.
Muhammad,
Thank you,
thank
Dr.
you, thank you. It was good to
Thank
see
you.
all
Thank
of you.
you. It was great.
Tiana, Dr. Ashraf, Dr.
session.
Danish, Dr. Muhammad Awadallah.
Thank you, Dr.
Thank
Ayman.
you, thank you.
So
Bye
Danish,
bye.
thank you very
Thanks a
much.
lot.
Really, I was happy that I see you
Pleasure.
after a long period of time.
Pleasure,
Tatiana,
Muhammad, pleasure.
Dr.
Thank
Ayman,
you
thank you very much. We are seeing
you.
you.
Hope
Thank
to
you.
see you in person soon. Bye bye.
Yeah,
Bye-bye.
bye-bye.
Nice to see you, Tatiana, again, you know. Long
Yes,
time.
and for me as well. Thank you. Thank you. See you soon.
Bye-bye.
Hope. Bye bye.
Bye-bye, Dr. Muhammad. Was
السلام
good to see
السلامة
you.
دكتور
عليكم.
أيمن.
شكرا
مع السلامة.
شكرا. عوض الله نشوفك قريبا
مع
ان شاء الله.
السلامة إن شاء الله. يلا
يلا.
السلام عليكم ورحمة الله.
سلام.
Salam.